The following podcast is part of a certified educational activity titled Staying on Track Toward Better CLL Outcomes, Delivering Effective Sequential Care Guided by Real-World Experience. Access the entire activity and complete the post-test at peerview.com/ABM860. Downloadable slides and practice aids are also available.
Good morning, everyone. Thank you for waking up that early and joining our session on staying on track towards better CLL outcomes. It's my ultimate pleasure to introduce the faculty. Myself, I'm Wojciech Jurczak from the National Research Institute of Oncology in Krakow. There's Tala Munir from Leeds Teaching Hospital, and Megan Thompson from Sloan Kettering Institute. Our goals for today is to improve your understanding of guidelines and clinical evidence supporting the use of modern targeted therapy in relapsing refractory CLL. Enhance your skills for developing personalized sequential treatment plans for patients progressing on treatment, and to provide you with guidance for making practical, patient-centered care and safety management decisions in a relapsing refractory setting. And let me give you a very, very short introduction on where we are. So, the first-line targeted therapy is really firmly confirmed based on dozens of well-planned, randomized clinical studies most of us participated in. Now, the only category of patients where we might even dare to offer chemoimmunotherapy are youngsters with a mutated status, EGHV status, without any risk factors. But even though it is allowed, not a lot of these patients are treated with chemoimmunotherapy. I can't even remember when I gave FCR regimen. Perhaps I'm old. Before we go any further, I would like to introduce what we have done in EHA. So as a part of the Guidelines Committee, I'm proud to say that you will see a totally renewed and updated EHA guidelines. And it's not a mistake. I'm not reflecting to ESMO guidelines. Thanks to Martin Dreiling and his consequent work, ESMO surrendered, and we will have hematological guidelines published in Hemisphere and e-updated every year on EHA page. This is maybe not that frequently updated as NCCN guidelines, but we try to keep it better. But if you compare EHA guidelines to NCCN, we look at the categories, and as you see in NCCN, it's more important what does the panel think, because Category 1A versus Category 2A differs whether there is a consensus of over 85% of panelists. And certainly Category 1A in both NCCN and EHA recommendations has to be based on at least one large controlled study, methodological without any problems, so with low potential bias, or the meta-analysis of such studies. Now, in the Category 2A versus 2, there is more, the Category 2 is better described in EHA guidelines. There are also some minor differences in how we treat it. So the preferred intervention is in NCCN, while in EHA we have a strongly recommended category where there's a strong evidence for efficacy with a substantial clinical benefit, while generally recommended it's a moderate evidence and a limited clinical benefit. Now the NCCN, the EHA guidelines, and that's I mentioned that ESMO is finished, but still the CLL, Barbara published it last in ESMO, in Annals of Oncology. These guidelines will be republished this year as a new version in Hemisphere. But we do have a situation where in the majority of patients who are of low or intermediate risk, we prefer time-limited options rather than continuous therapy. And in here, at least that's one of the few cases where we in Europe are superior to US, because we do allow the combination of ibrutinib and venetoclax, and recently the combination of acalabrutinib and venetoclax plus minus obinutuzumab, while in the States the combination of BCL2 and BTK inhibitors is not yet neither allowed nor approved. In a relapsing refractory setting, again, the therapy depends on how we did treat in the first line, but once we have a progression after Bruton thyroid kinase, specifically in the patients who are double refractory, we think of a non-covalent BTK inhibitors, namely pirtobrutinib. If you look at the NCCN guidelines, it's more a list of possible options than a guideline, but pirtobrutinib is also marked as the option for the double refractory patients. Well, the CAR-T is a good question. Not all of us are absolutely certain that we should go for it, but Megan will give you a more clear insight on that. As for regulatory status, this is again what we are proud of in Europe. As you see, in Europe we have approved both ibrutinib and venetoclax and acalabrutinib and venetoclax, which is not approved in the States. Otherwise, pirtobrutinib remains the only non-covalent BTK inhibitor approved, while nemtabrutinib, we have the results from the phase 3 study, it's not yet approved. Venetoclax, the old venetoclax, is approved everywhere. Before we go any further, I would like to take you to history. If we are treating the relapsing refractory patients, we should think when the patients were originally treated. If it happened before 2010, still the majority of patients could have been treated with chemoimmunotherapy. In the decade 2011-2020, literally half of the patients could have been treated with chemoimmunotherapy. It dramatically changed in 2021. We had the dominance of BTK inhibitors, with 25 to 30% of patients being treated by venetoclax-based regimen, and this further changed in last year, where more or less we have the same amount of patients treated with BTK-based regimen and venetoclax-based regimen. So we have three major clinical situations to discuss for relapsing patients after venetoclax-based regimen, BTK-based regimen, and those who are double refractory. Again, the same thing here. So if we have the patient progressing on a covalent BTK inhibitor, we can choose either a venetoclax regimen or a pirtobrutinib. If they relapse after venetoclax with obinutuzumab, we can either repeat therapy, particularly if a relapse is late, or change it for covalent BTK inhibitor. However, if we have upfront the BTK and BCL2 inhibitor and they relapse or there is no response, we should go for pirtobrutinib. And there is a marked difference in prognosis between the patients who are really refractory to the double combination or those who are exposed to the combination but were not refractory to it. It's a small study, but it represents the trend. It's seen both in progression-free survival and overall survival. Now let me pay tribute to CLL Society, who provided us with the slides reflecting patients' perspective, which is really important. So what do our patients think about CLL, about their disease, and what they are afraid of. It occurs that literally half of them have worries over treatment options and relapse, and with a similar frequency, there's an anxiety over potential toxicity. So it's not just the prognosis, but the adverse events we have to discuss with our patients. Now, this is something new because 15% of patients have concerned that a fixed duration therapy may not be sufficient. That's something which is odd because developing those time-limited regimens, we thought that the patients would love it, because we thought that if we can treat the patients for 18 months or 2 years and then let them go, everyone is happy. It's not the case. Now, that's our drawback. Unfortunately, in 8% of the patients, they think that they were not informed correctly. They didn't receive a meaningful information. So we need to improve on that. The majority of patients received or think that they received the correct information, and 65% remains in this belief. However, in a quarter of the patients, they do agree with us, they feel confident at diagnosis, but then they start having doubts at relapse. Tala Munir, who will have a absolutely smashing presentation on sequential care, understanding the prognosis factors and mechanisms of resistance. Tala, the stage is yours.
Thank you very much, Professor Woyek, and thank you very much, PeerView, to ask me to come and talk. So my topic for discussion is preparing for sequential care and understanding the prognostic factors and resistance in CLL patients. So consensus on the key baseline prognostic factors in CLL is reasonably well established, and IWCLL actually gives very good guidelines. So this table goes through the different diagnostic tests that we should be doing, some in general practice and then some in clinical trials. So for example, FISH for common modalities like 13q deletion, 11q or 17p should be done, as well as trisomy 12. If we look at the conventional karyotyping and peripheral blood lymphocytes, and this is mitogen stimulation, that's not generally indicated in normal practice, but in clinical trials it's desirable because we want to know how these patients are doing with different lines of therapy, and there's accumulating data with complex karyotype that some patients are not benefiting from the different therapies that we have at this moment in time. And TP53 mutation should always be tested, as well as IGHV mutational test. And serum beta-2 microglobulin, it's a desirable test to be done, but always is done in clinical trials and actually does come up as a prognostic marker in most of the studies that we look at. So the ESMO recommendations for prognostic assessments, if you look at the initial staging at diagnosis, pre-treatment evaluation, and at the end of therapy and in the follow-up, you've got different ways to assess your patient, but some are common things like your normal common examination, CBCs, and serum chemistry. But then if you look at the cytogenetics, it should be done at initial staging at diagnosis only if clinically indicated or if the patient does want to know a prognostic score. But it is absolutely essential before a pre-treatment evaluation. If you look at the IGHV mutational status, again, you can do that right at the diagnosis or just at pre-treatment evaluation, but it's a useful test to give a good prognostic indication to the patient. So I would just do it once at whichever time point you choose. And the bone marrow aspirate trephine biopsy, that's usually is indicated in clinical trials, or you have got other reasons where you need to go in and find out the cause, for example, for cytopenias. And then you have to do the hepatitis, CMV, and HIV serology, and CT scans mostly are indicated in clinical trials now. But if you look at the favorable and unfavorable prognostic factors in there of targeted therapy, I've just highlighted it in the table. So if you look at the FISH analysis, we need to do the 17p deletion and repeat it at each relapse, because I think it's one of the most important prognostic marker. And based on the current NCCN guidelines, it's associated, clearly associated with poor outcomes with chemoimmunotherapy, but again with fixed duration venetoclax-based therapy and covalent BTKI inhibitors, we're seeing shorter PFS and overall survival, but the data is, as the data mature, we get more and more information about that. If you look at the TP53 mutation, again, you have to repeat it at each relapse. And if you find the two groups that you need to look at, one is the TP53 mutation with 17p deletion, and really it has got inferior outcomes with whichever therapy you are going to use. And then again, a TP53 mutation without the 17p deletion, but outcomes may be slightly more favorable as compared to the patients who've got dual hit. In terms of the IGHV status, you have to just do it once. It doesn't change in the lifetime of a CLL patient's journey, but we know now that the unmutated IGHV status is associated with shorter treatment-free interval and PFS with chemoimmunotherapy and fixed duration venetoclax regimens versus mutated IGHV. And the complex karyotyping, which needs to be done and repeated at each relapse, it is now shown to be of inferior survival and shorter time to progression with the different therapies, but it is quite a tedious test to do, and not all the labs are able to do it. So it is mostly done in clinical trials at this moment in time, and there are lots of other techniques by which people are trying to look at the complex karyotyping. If you look at the consensus on the key baseline prognostic markers and recommended by the guidelines, the most important biomarkers are the IGHV mutational status, 17p deletion, TP53 mutation, and complex karyotype. And if you look at the different groups like BTKI inhibitors with or without anti-CD20 or venetoclax-based therapy, you can see that the IGHV unmutated status has got a probable prognostic significance in the BTKI era, but with venetoclax-based therapy, it's definitely there. Also with the 17p deletion or TP53 aberration, it's there. There's uncertainty about the other gene mutations, and most patients are doing reasonably well. And again, with the complex karyotyping, we're seeing that. In terms of the MRD, it's being used in the clinical trial. The prognostic significance is pretty clear with venetoclax-based therapy. With the BTKI-based therapy, it's unclear or uncertain. And then looking at the new drug-specific mutations, the prognostic significance is unclear at this moment in time. So I'm just going to briefly talk about the resistance and other factors that inform progression and treatment discontinuation now. So I think throughout the BTK era, we know that there are two main reasons why patients are stopping BTKI inhibitors. And when you look at different prospective studies or real-world data, it becomes very clear that you've got CLL progression at 19%, but the other reason why patients are stopping therapy is probably adverse event. And if you look at the cumulative incidence of discontinuation, the disease progression happens over a number of years. This is both data for ibrutinib and acalabrutinib, but adverse events make a main reason why patients are stopping therapy. So that leads to the argument about the double refractory and the patients who are intolerant to BTKI inhibitors. And the other thing to remember is that the treatment-naive patients and the relapse refractory patients, the drug-specific mutations related to BTKI inhibitors differ tremendously. So if you look at the frontline patients, the BTKI mutations, drug-specific mutations, are only seen in about 3% of the patients who received continuous ibrutinib therapy, as compared to 30% in the patients who had relapse refractory disease. Similar kind of pattern was seen with the PLC gamma-2 mutation and the co-occurring BTK and PLC gamma-2 mutation. So suggesting that if your clone is a bit more resistant, there's more chance of acquiring the BTK mutation. And in a recent meta-analysis, what the authors found that the BTK and PLC gamma-2 mutations were found in nearly over half of the patients who experienced disease progression whilst on BTKI therapy. And the cysteine 481 binding mutation remains the most predominant BTK mutations treated with either ibrutinib or second-generation BTKI inhibitors such as acala or zanubrutinib. And that confers resistance to all available covalent BTKI inhibitors. But not only the BTKI resistance is related to the drug-specific binding site mutation. This is quite a good work to look at other factors. So if you have TP53 mutation or deletion, there is a high risk of acquiring the drug-specific mutation. Deletion of chromosome 8, short arm of chromosome 8, and high CD49D expression in ibrutinib relapsing patients was other factors which lead to increased risk of BTKI resistance. So in terms of guidance on BTKI resistant testing, mutation status alone is not an indication to change treatment. So if you are testing for BTKI resistance, it may have clinical applications in future, can be used to document resistance or addition of other therapies, may inform your decision what your next step should be. But the decision to change treatment should be based on clinical progression. And sometimes what you find is that you might find a very small clone and that evolves over time, but at the same time, sometimes that might be just a subclone and just stay like that for a long period of time. So clinical progression instead of BTKI resistance development should be the bar to change therapy. And that takes me how you can overcome the resistance. In terms of the non-covalent BTKI inhibitors, what pirtobrutinib does is that it binds to the ATP pocket reversibly, and essentially it doesn't need the cysteine 481 to bind. So it is binding to different sites on the BTK protein, and as a result of that, you still see efficacy with pirtobrutinib. And it also binds to both wild-type BTK and the BTK harboring the cysteine 481S mutation, and it overcomes common resistant mutations such as those to C481S. If you look at the toxicity data in terms of discontinuation, this is a real-world study which is investigating the dose reduction or discontinuation with ibrutinib in patients with CLL. And you can see that there is quite a substantial number of patients where dose interruption happened. But again, when you're looking at the discontinuation due to adverse events, you've got a number of factors like infection, cardiovascular events, hematological toxicity, AF. And really the point I'm trying to make here that these discontinuation, these adverse events are really rare, which essentially leads to discontinuation of therapy. And if you look at the long-term discontinuation data, we are seeing in RESONATE-2 there was a 33% discontinuation rate due to adverse events. That's the longest follow-up, up to 10 years. And when we look at the second-generation BTKI inhibitor in the ELEVATE-TN study, there was 20% discontinuation rate due to adverse events with acalabrutinib, and in the Sequoia study, at a 5-year follow-up, zanubrutinib had a discontinuation rate of 8.3%. But when we go to the real-world data, and this is a nice poster from Caroline Owen presented yesterday, and essentially what the authors did was to look at the median time to next treatment or death after, for the first therapy initiated after covalent BTKI discontinuation. And essentially what they were looking at that the patients already had the first-line therapy, and then they move on to the second-line therapy. And actually, in the real world, the responses are not as good as what we saw in the clinical trials, highlighting the fact that actually we have very little data in the relapsed refractory space when we're using targeted molecules, and we all believe that actually these patients will do fine if we are re-exposing these patients to the similar drugs. But actually, in reality, the data in the real world looks slightly different, and we really need to know how best to treat these patients, because this is really devoid of a lot of evidence at this moment in time. And I think over time, overcoming intolerance question is important. And I think in terms of we want to get the best out of our covalent BTKI inhibitors. So we're just showing you these kinome effects with ibrutinib having multiple red dots, and that's why you've got quite a lot of off-target effect. Then you have got acalabrutinib, which has got predominantly very specific BTKI blockade, but then zanubrutinib is somewhere intermediate between the two. And the head-to-head trials do show that more selective BTKI inhibitors have got fewer target effect, off-target effect, which contribute to less toxicity versus ibrutinib. And when we look at the non-covalent BTKI inhibitors versus ibrutinib, like nemtabrutinib and pirtobrutinib appears to be much more selective, whereas nemtabrutinib has got multiple other kinases that is blocking. These are reversible non-covalent BTK inhibitors, but there is no head-to-head data, and there are frontline studies as well as some relapse study looking at this question, whether these drugs would be more tolerable. So I will conclude this part of the session to say that traditional prognostic markers, including TP53 aberrations and IGH remutation, retain their prognostic significance in the era of targeted therapies, especially with the fixed duration therapies. We need to remember that. Complex karyotype is an emerging prognostication marker, but clinical application is still difficult to establish just because it is quite a labor-intensive job. There's a potential risk for Richter's transformation in complex karyotype patients. Lastly, TP53 mutation or 17p deletion confers high risk of developing BTKI-resistant mutations, and the non-covalent BTKI inhibitors have the ability to overcome mutations developed during treatment on covalent BTKI inhibitors. And with that, I'll hand over to my colleague, Megan Thompson, and she will, I'm pretty sure, take you through the clinical data.
Okay, thank you so much. So this sets the stage for really delving into some of the newer treatment options for relapsed and refractory CLL. And before we move forward, this was alluded to in the earlier retrospective study during the introduction, but with all the available targeted therapies now in CLL, one of the really important things is to differentiate really between those patients who are refractory or progressed during or shortly after a covalent BTK inhibitor and a BCL2 inhibitor versus those who were exposed to the therapy but perhaps discontinued the treatment due to completion of planned therapy and fixed duration therapy or reasons such as side effects rather than really disease progression. So this has led to a concept of double exposed and double refractory. And double exposed we're defining as really patients who were exposed to these agents but discontinued for intolerance, for example. Those who completed fixed duration therapy with, for example, venetoclax and obinutuzumab or a BTK and BCL2 inhibitor, but then progressed shortly after. And while this time interval after completion of fixed duration therapy is still an area of ongoing investigation, really progression more than a year or two after, we would say more as double exposed, whereas progression certainly under a year after end of treatment with fixed duration therapy is more in this double refractory category. And I think, right now, with the continuous therapy era, certainly for covalent BTK inhibitors, we do see a lot of these double refractory patients when venetoclax was continuous. But now as we move towards fixed duration strategies in the front line, I would anticipate that you'll see a little bit change of this population where we have more double exposed patients, less double refractory potentially, but we'll have to see how that evolves over time. So let's talk a little bit about retreatment, and this is a concept that's come up mainly because we have fixed duration strategies both in the front line and relapse refractory setting, starting really with venetoclax-based therapy. So here you're seeing follow-up, 7-year follow-up now from the Murano study, which as a reminder was a pivotal study of venetoclax plus rituximab for a 2-year fixed duration regimen in relapsed CLL with the control arm of bendamustine and rituximab. And certainly we see at the 7-year mark, the progression-free survival for venetoclax rituximab is 23 months, with a 7-year overall survival of 70%. And venetoclax rituximab was significantly better in terms of progression-free survival than the chemoimmunotherapy arm. But one of the really interesting pieces of data that's come out in this publication earlier this year is looking at patients who are retreated with venetoclax after fixed duration of venetoclax rituximab. And again, this is in the relapse setting. They reported on 25 patients with a median progression-free survival of 23 months. And so this is quite a heavily pretreated patient population, and we would expect perhaps venetoclax retreatment to be even better in earlier lines of therapy. This is retrospective data looking at the same question. So this was an international effort to look at patients who got an initial ven-based regimen in any line of therapy. Most of these patients were relapse refractory and then went on to get another venetoclax-based regimen. There was a median of 16 months between the two therapies and a median progression-free survival of 25 months with an overall response rate of 80%. So really proof of concept earlier data showing about venetoclax retreatment. And there are now ongoing prospective studies looking at this. For example, yesterday there was a poster on the REVENGE study. They've reported on outcomes of 15 patients, and so far patients are responding to retreatment. So this is going to be very important as we move forward with patients who get initial fixed duration treatment and then progress later. Can we just recycle the therapy? So this is looking at data from Captivate. And so as a reminder, this is the doublet combination of ibrutinib plus venetoclax, and looking at what happens next. And this is one of the data gaps where we're seeing some more data, but again, there isn't a huge amount of data right now on what to do after a BTK BCL2 inhibitor doublet in the front line, which is now, this regimen is widely used in Europe, and we have new data from the AMPLIFY trial with acalabrutinib and venetoclax. So when we look at 61 patients who had progressive disease with CLL after the completion of fixed duration ibrutinib venetoclax, 36 have initiated retreatment as of this data cutoff, and there will be an updated abstract tomorrow presentation. And most of those patients got single-agent ibrutinib, so 25 patients, but there was a smaller amount, 11 patients, who were treated with the combination therapy. And you see the response by cohort, both for the single-agent ibrutinib cohort as well as the combination cohort, high overall response rates nearing around 80%, with a 1-year progression-free survival and overall survival of 100%. For the combination, and over 90% for ibrutinib monotherapy, which has a little bit longer follow-up. This is a really important study as well that has an updated poster this evening. So this is the HOVON REVEAL study, and this is a phase 2 study, and it looks at patients with CLL who receive fixed duration venetoclax or obinutuzumab or venetoclax rituximab. And 44 patients, so smaller study, but I think it's really important proof of concept that they actually got retreated with 2 cycles of acalabrutinib followed by 24 cycles of the combination of venetoclax acalabrutinib. So this is looking at first duration venetoclax-based therapy. What is the next best treatment? And here it's looking at a BTK BCL2 inhibitor combination. I'd say, so far, early follow-up, just 15 evaluable patients, and the primary endpoint was actually undetectable minimal residual disease. About 21% of patients, again, small numbers, so 3 of 15, had bone marrow undetectable UMRD, but the response rate was quite high, with patients having a majority partial responses and some complete responses, and patients did not stop due to toxicity. So again, I think we'll see more and more data as time goes on and longer follow-up, but this looks at BTK BCL2 for perhaps patients who got venetoclax obinutuzumab in the initial setting. This will be important. So let's talk about some of the newer agents now, including CAR T-cell therapy and non-covalent BTK inhibitors, and we'll preview some newer mechanisms of action and some data that you'll see at the EHA meeting. So this is looking at the phase 1/2 Bruin study, which looked at pirtobrutinib. This was the initial study of safety and preliminary efficacy. And we see overall median follow-up of over 2 years in this data presented. All patients in this presented cohort had a prior covalent BTK inhibitor with an overall response rate of 81%. This is a heavily pretreated patient population, a median of 4 prior therapies. And you can see that there's patients who are BCL2 inhibitor exposed and BCL2 inhibitor naive. And so in BCL2 inhibitor naive patients, a median progression-free survival of 23 months versus those exposed slightly shorter at 16 months. And the other important thing to note is there were patients who had prior discontinuation of pirtobrutinib, not just for progressive disease, prior discontinuation of the covalent BTK inhibitor, not just for progressive disease, but also for intolerance. And the discontinuation rate for pirtobrutinib on this study was quite low, just about 6% of patients discontinuing for a side effect or adverse event. And so I think this supports the sequence going from covalent BTK inhibitor discontinuation for intolerance to pirtobrutinib. And then on the right of the screen, you see that in the specific BTK intolerant cohort that was looking, we see data specifically with a median progression-free survival of 28 months. So looking at the phase 3 data, this was presented at the ASH meeting and recently published in the Journal of Clinical Oncology earlier this month. This is looking at pirtobrutinib versus the control of idelalisib plus rituximab or the investigator's choice of bendamustine rituximab. And we see overall that pirtobrutinib reduced the risk of progression or death by 46% when looking at the IRC assessment for these patients. So 119 patients in either arm, median follow-up just under 2 years, and that has a ratio of 0.54 favoring pirtobrutinib. I think one of the really important highlights of this data is looking across higher risk subgroups, including patients with P53 mutation and or deletion, which we know are higher risk, and IGHV unmutated CLL, which made up the majority of the cohort. We see that, for the unmutated patients and P53 variant patients, pirtobrutinib was favored. In addition, complex karyotype, which we know is really important with covalent BTK inhibitors as a prognostic factor, these patients also did quite well with pirtobrutinib compared to the control arm. Here we see time to next treatment, and in CLL this is a very relevant endpoint because not all patients need to necessarily immediately switch at the time of true IWCLL clinical trial progression, and you can see that the time to next treatment, the median for the pirtobrutinib arm was 24 months, which is a little bit longer than the median progression-free survival. So there are these patients on BTK inhibitors that can have a little bit slower cadence of their progression, and so it was about 2 years before they needed their next treatment. And you see a little bit of a bigger gap here compared to the investigator's choice arm. There's data that's going to be presented this evening looking at patient-reported outcomes, and there were 3 outcome surveys that these patients underwent in the Bruin CLL 321 study looking at CLL-related symptoms, physical functioning, and fatigue. And you can see at different time points over the therapy, this negative LSMD score indicates favoring that the symptom burden was lower with pirtobrutinib, and that was really across the board and persistent throughout the study, suggesting an improvement not only in progression-free survival, but in patient-reported outcomes and quality of life for patients treated with pirtobrutinib. So is there a role for time-limited pirtobrutinib in relapsed refractory CLL? So here's data that was presented looking at the first use of pirtobrutinib in combination with venetoclax, and then there was a cohort where rituximab was added as well, with very high response rates. So overall response rate of 94 to 100%, depending on the cohort, and these responses at an 18-month follow-up, the duration of response appeared to be durable, over 80%. And this really sets the stage for several trials that are ongoing, but there is a randomized study of pirtobrutinib, venetoclax, and rituximab versus the Murano regimen as the control arm. Thinking about practical considerations, similar to other BTK inhibitors, keeping in mind side effects such as bleeding, infection, secondary primary malignancies, and then neutropenia being the most common grade 3 or higher hematologic AE should be paid attention to, and there are dose modifications based on renal function that are recommended. Nemtabrutinib in the BellWave study showed a preliminary activity with a response rate of 36% when looking at all dose levels, and then 75% at the 65 milligram daily dose. This was in 8 patients. And there is a phase 3 study, as was mentioned earlier, that's looking at relapse refractory CLL, nemtabrutinib plus venetoclax versus the Murano control arm in the relapse setting. So let's just close out here by talking about some of the newer therapies, and we can get into this in the discussion more as well if there's questions about where these fit in, and I think it'll be interesting to discuss. So liso-cel is a CD19-directed CAR T-cell therapy. The Transcend CLL 004 study looked at this in patients who were no response or ineligible for a BTK inhibitor, and then had a more than 3 therapy cohort if they had standard risk disease with some higher risk disease features, 2 or more prior therapies. And these are the results for the BTKI progression and venetoclax failure subset, 49 patients. And the take-home message here, I would say, is a small number of patients had a complete response, about 18% of patients. So the complete responses weren't the majority of patients, but those you can see in the PFS curve who had a complete response had a very durable response. Looking at the median progression-free survival, it's not quite high, but I think that's really skewed toward the non-responders and then those with a complete response. This did lead in the United States to the FDA approval on patients with relapsed CLL who've received a BTK and a BCL2 inhibitor. And then to preview a newer mechanism of action, and this ties into some of the resistance, BTKI resistance work that was presented earlier in this talk. There's several BTK degraders that have entered the clinic, and these molecules bind BTK on one end, and they bring BTK in close proximity to the E3 ligase. They tag BTK for proteasomal degradation and degrade BTK rather than inhibiting the target. And there's data that has been, there was a poster last night updating bexobrutideg, or Nurex 5948, which is a BTK degrader in relapse refractory CLL, and you can see an overall response rate of 81% there, including in patients with BTK resistance mutations. And there will be updated data presented by Dr. Scarfo tomorrow on BGB 16673. The most recent data we've seen is an overall response rate of 80%. So I'd like to highlight, before we move on, the CLL Society's Clinician Resource Library. The CLL Society has a wealth of resources that are available to clinicians online. There's a QR code here where you can find these, and they range from everything from medication fact sheets to topical handouts. And so not only are they providing patient educational material, but there's material for clinicians as well that can be quite helpful when you're seeing CLL patients in the clinic. So with that, we'll move on to, I'll hand it back to our chair, and we'll move on to our next session.
Now, this part, we'll present to you a couple of cases we prepared and perhaps discuss them. So the first one is a 77-year-old woman with relapsing refractory CLL. She had unmutated EGHV status, no other risk factors, no 17p deletion nor mutation. She had type 2 diabetes. In the first line, she was treated with obinutuzumab with venetoclax. And she experienced somehow, it was a disappointment, a remission lasting less than 1 year. It was reconfirmed that she didn't develop a 17p deletion nor TP53 mutation. So in the second line, she got ibrutinib with a 3-year remission. The progression was with lymphadenopathy. She was in performance status 2, and therefore, what shall we do? So may I ask the penalty, should you perform BTK resistance?
So I think for any patient progressing on a covalent inhibitor, I think the point that was made earlier is a really good one. I think that BTK resistance testing can add, if in certain cases, to confirm progression, but it really should be the clinical progression that has you switch therapy. So you wouldn't want to switch therapy just because of the resistance mutational testing. It's not always available to clinicians. At my center, we do have it available, so we often do test, and it's additional information. But really, it should be the clinical progression of the patient, because we know these mutations can actually occur earlier, and patients can continue on, for example, the covalent BTK inhibitor for several months than a year. So I think this is an emerging area, how we really would use this testing in clinical practice.
Yeah, I would agree to that. I think clearly this patient is in trouble because she's really a double refractory patient. This is the patient we would worry about. The only thing I would say is that resistant mutation may help us to just think about how to treat the patient, but actually our options are pretty limited with this patient anyway. The other thing I would say is that we do see these patients who've got unmutated IGHV but no TP53 aberration, and that's where the role of more molecular testing or complex karyotype comes into play. Because I think this is the kind of patient where that kind of information would be useful, primarily for prognostic reasons as well, to tell to the patient. But our options with this patient are pretty limited.
And besides that, the availability of BTK resistance testing is relatively low outside clinical studies.
Yeah, it is. I think it depends on which center you are working in. It is primarily available on most of the lymphoid gene panels now that are used. But at the same time, clinically, would you do anything different with this patient is the main question.
Well, in a way, it's a hassle. It's just a couple of centers in the country which do it. Now, does the length of remission, particular after Obi-Ven regimen, inform us what shall we do? Because less than 1 year remission in case presented is less than satisfactory. So what are your thoughts about repeating Obi-Ven versus switching to BTK inhibitors?
Yeah, I mean, I think this is a really high-risk patient with less than a year remission after frontline venetoclax obinutuzumab. That's quite short, and so I would not favor venetoclax retreatment necessarily in this situation. I would probably try to go with an alternative mechanism of action, such as a non-covalent BTK inhibitor. But to the point that was made, it's really a high-risk situation, and we know that patients can develop resistance to non-covalent BTK inhibitors, including pirtobrutinib. So thinking, in the United States, we do have CAR T-cell therapy available, so it's almost like a question of sequencing at this time. You're going to go to pirtobrutinib, but you should really be planning your next step, whether that's CAR T-cell therapy or another clinical trial if available. So it's not that you would never use venetoclax again, but I think that the remission duration would be short, and I would favor going to a non-covalent inhibitor.
So let's make it less evident. If she relapsed 3 years after, would you retreat her or would you switch?
Yeah, I think the options, if she had 3-year remission to obinutuzumab, venetoclax, you may want to think about re-exposure to venetoclax, but as Megan quite nicely showed the Murano data, that patients who relapsed after receiving Venar, their second PFS was nearly half as compared to the first time they received the Venar therapy. So I would still pursue non-covalent BTK inhibitor. Her performance status is 2. We want to get her better. I think going on to a drug which is probably going to give her a decent remission is going to be fine. But I think at the same point, you can reuse venetoclax, but I wouldn't expect 3 years of PFS.
And perhaps I want to draw attention to one inconsistency. We can treat patients with venetoclax and obinutuzumab in the first setting, while the relapse, we can just, in some countries, rely on a Murano study, or victory under Murano, as I call it, but that's venetoclax with rituximab, so inferior monoclonal. Now, going back with discussion, I think we covered this first question, retreatment with venetoclax or covalent, but would you switch to non-covalent BTK inhibitors or CAR-T?
Yeah, so I think, in the situation we talked about where it was less than a year remission on Ven-Oben and then true clinical progression on the covalent BTK inhibitor, it really is a sequencing question of non-covalent BTK inhibitor CAR-T or another clinical trial. One of the things to keep in mind with CAR-T is it's very different than administering a non-covalent BTK inhibitor. You really have to plan ahead of time. There's a lot of logistics involved with it. And so you have to plan for the cell collection, the manufacturing, so there's a period where you'll have to control the disease, and I do think pirtobrutinib is a tool, for example, in this case, where that could be done. And then in many centers, the CAR-T administration itself, and not only is there the lymphodepleting chemotherapy, but there's a period required of hospitalization, which is very different than this patient who is used to getting an oral covalent BTK inhibitor and then, perhaps even the non-covalent BTK inhibitor while the CAR-T was being manufactured. And then there's long-term side effects as well of CAR-T to keep in mind, things like cytopenias, infection risks, and hypogammaglobulinemia. And so there's a lot of counseling that goes in both for the short-term cytokine release syndrome toxicity, ICANS, which requires intensive monitoring, and then really planning for the long-term as well.
Well, pirtobrutinib has one charm. It's absolutely magnificently tolerated. If you look at the adverse events in CTCA grade 3 or higher, they're one-digit numbers. And besides, everyone likes blue tablets. But talking about logistics, do you think that with a 77-year-old patient, are we justified to offer them CAR-T cells regarding some logistical problems? Or at least should we try non-covalent inhibitors first?
Well, to me, the answer is pretty, well, I can't use CAR-T cells in Europe anyway, and UK as well. We have got non-covalent BTK inhibitor to go to really here, or clinical trial. And we've got reasonable data on PERTO, but like what Megan said, that if we're going to pursue some kind of a strategy to see what's the next steps, whether you look out for a clinical trial with a degrader or you're looking at other options in clinical trials, is the route which I would normally take. The issue really is that if this was a young patient and you were salvaging that patient with PERTO, I think in that patient still in our jurisdiction, we have an option of allogeneic stem cell transplant, but you won't offer an allogeneic stem cell transplant to a 77-year-old And I think in terms of the CAR T-cell therapy as well, you need to be really careful with your patients before you choose CAR T-cell therapy. It's not for everyone, whereas I would argue you can give PERTO to any patient.
We have treated over 100 patients with pirtobrutinib in our centre, and only a few went to the CAR T-cells. Our preferred option after failing pirtobrutinib was subjecting them to clinical studies. Of particular importance, we regarded giving them sonrotoclax or other newer generation BCL2 inhibitors. Now let's go to the second case. Now we have an 80-year-old man, mind you, just a couple of years later, but a male. So a much more difficult case, relapsing refractory CLL. Initially, he had mutated EGHV status, standard risk cytogenetics, atrial fibrillation, and he was on anticoagulant therapy. Despite that, he was started on first-line acalabrutinib, and he had this for 4 years. There was a sustained response. However, after 3.5 years, he developed grade 2 arthralgias, myalgias, worsening to persistent pain, a very infrequent but sometimes existing adverse event. Minimum improvement was with dose interruptions and classical non-steroidal anti-inflammatory drugs. And they decided to discontinue the therapy. So what's the next step? Would you at that time switch it to another covalent BTK inhibitor, use pirtobrutinib, or switch to venetoclax? Difficult question.
Yeah. I think, I'm going to add in another option just thinking about this case off the bat. I think the first step is really to assess his disease status. So was on a covalent BTK inhibitor, Cala, for 4 years. There are some patients that stop a covalent inhibitor for intolerance or side effect, and then they can have a period where they actually don't need any therapy. So, for example, there's data from the ECOG 1912 study, patients treated on the ibrutinib rituximab arm who stopped therapy. It was about 2 years before they progressed and needed treatment. So I would first kind of do that, reassess the situation and see, but then you do have a lot of other options here. This is one of these exposed patients, but they haven't developed resistance to the covalent BTK inhibitor class. And if available, you could consider, for example, zanubrutinib. And there are patients, and there is data to support this, that can go to another covalent BTK inhibitor and not have the side effect. But, there are these other options, non-covalent inhibitor or venetoclax. I usually try to stay within the class if it's a minor side effect like this, but curious to hear others' thoughts.
My thoughts are pretty much similar, really, to be honest. I think in terms of some of the patients on BTK inhibitors going up to 4 years or more, and they have consistently taken those tablets, usually will have a very decent response, and they might be in decent depth of remission. And in those patients, sometimes you can just stop therapy, wait for clinical progression to happen, and once that happens, you can go to an alternative covalent BTK inhibitor, which we mostly prefer to go to Zanu there. But at the same time, it's a reasonable option to change the therapy to different class of drug or use a non-covalent BTKI inhibitor, PERTO, at that point. But the point, I think it's important to remember that the discontinuation due to adverse events are pretty common. And if they happen in the first couple of years, then moving to the next line of therapy or switching within the same class makes sense. But if the patient has had a decent exposure to these molecules, then you still take a step back and see what the clinical state is at that point. So I think all of those options are valid, and I think it's a discussion with the patient which route we want to take, explaining everything. The only thing I would say is that he's already got atrial fibrillation, he's on anticoagulant therapy, so you might want to consider BCL2 inhibitor in this patient based on that. But again, a lot of our patients on BTKI inhibitors have got AF and they're already on anticoagulants, so we manage that quite well now.
So I think we all agree that we should distinguish between patients who progress on BTK inhibitor therapy and those who, for whatever the reason, discontinue them, just because the clinical study is terminated. Some of them do surprisingly well and do not require therapy for months. Now, if you have to inform the patient, what would be the arguments for switching versus trying to manage his quite rare complications, arthralgias, pain?
I think it's not a rare thing to see arthralgias and myalgias. I think the issue is that it's doesn't feel that important to us as clinicians. I think for patients that could be quite a tedious side effect, actually, if they keep on taking some ibuprofen every day to kind of control this. So I do think that we have got options now to switch therapies, and I think we should consider talking to patient about this, considering the patient has elected himself to discontinue therapy here. We need to talk to the patient and see, we can go back to the same class of drug or other BCL2 inhibitor. But I think it's very much a discussion that's kind of focused on patients' view on this as well, because really it's again, evidence-free zone.
And mind you, that's the 80-year-old individual. Therefore, we have a lot of other options, and making his life a misery maybe should not be on the top of our priorities. Now, the next case, an older patient with multiple comorbidities and high risk. So the nightmare, 82-year-old man, relapsing refractory, with at presentation unmutated EGHV status, 17p deletion, multiple comorbidities, but surprisingly 5 years remission on ibrutinib, and then progressing with B symptoms, splenomegaly. Certainly 17p deletion was confirmed, and the performance status was 2, however, declining. So in this elder and frail patient, what is the best next step? And how would you engage this patient in a discussion on sequential treatment after a long remission? So we have evidently the patient with a progression on therapy.
Yeah, so this is something that's coming up in the clinic, I would say, quite frequently, because there's many patients who got first-line ibrutinib and then have an excellent response for a period, but then have progression. And this is a higher risk patient, so p53 aberrancy with the deletion of p53 here, and then the age, I think, is a consideration here as well. So I would not treat the patient with another covalent BTK inhibitor, such as acalabrutinib or zanubrutinib, because as we know, there's overlapping mechanisms of resistance there. And so I do think it's time to switch classes here. There's data that we saw in the presentation to go, the venetoclax has been the traditional option here, but now with pirtobrutinib, I do think that's a consideration. There's data from both the phase 1/2 as well as the randomized phase 3 Bruin 321 study, where there are patients who haven't had venetoclax exposure and then go directly from a covalent inhibitor to a non-covalent inhibitor. A lot of times when I discuss this with the patient in the clinic, there are logistical considerations that come into play. So venetoclax has the ramp-up period, so you'll have to talk about tumor lysis monitoring, and pirtobrutinib does have a very similar administration to ibrutinib, which the patient was on, and a little less intensive monitoring at the beginning of therapy. So I don't know that we have enough evidence to say one option is better than the other, so it's really a personalized discussion with the patient.
So rephrasing this question again, if you have ibrutinib, which allows to achieve inhibitory 50 concentration for something like 6 hours a day, acalabrutinib twice 5 hours a day, and zanubrutinib, which is supposed to be this perhaps the strongest, it's 24/7, so it covers round the clock. Would you think that switching from ibrutinib to zanubrutinib is reasonable, or should we forget altogether about covalent BTK inhibitors in this case?
I would be reluctant to change to zanubrutinib, really, in somebody who's tolerated ibrutinib for such a length of time. So I think if it was quite early on, I think this patient has had a very good response to ibrutinib for 5 years. He's done very well. Unless there is intolerance question or dose reduction question, I think you can, in this kind of patient, can do the mutation testing to reaffirm what you think is going on, that this patient might be acquiring this resistant mutation, and that firms up your decision. I think if you check for the resistant mutations, it opens up a can of worms again, that whether you're looking for L528, T474, or Cysteine 481. So I think it does need to be taken into that perspective. But essentially, if somebody has had a decent response to a covalent BTK inhibitor for such a length of time, I would move to either venetoclax-based therapy or pirtobrutinib. And I think those are the choices that we need to discuss with the patient. Needless to say that when we are going to be using ven or pirto in this case, probably the remissions, the PFS might not be as long as what we see with other patients.
Now, in the era of a combination fixed-time regimens, we tend to forget that venetoclax is also approved in monotherapy without any time limits, and it proved to be quite effective in 17p deleted cases. Therefore, in this particular case, would you rather go for non-covalent BTK inhibitor, or would you rather go for the old venetoclax, given until progression?
Yeah, I think both are really good options. I think it's probably not a question in this patient of which one. They'll probably get exposure to both, assuming the patient stays relatively healthy, and so it's more of a sequencing question. I do think the ven monotherapy is an option. It's a little bit simpler. You do spare some of the anti-CD20 toxicity in coming for infusions. I do think that it depends a little bit. Probably I'd see the lymph node size, what their tumor lysis syndrome risk is, because that could also affect your venetoclax administration. Do they need to be hospitalized for the ramp up? And I don't think we really know which one is better. So I think both are good options.
Well, I remember we've done a kind of retrospective analysis, which could be titled Never Mess Up with Venetoclax. We took pirtobrutinib patients who relapsed after pirtobrutinib, and then 80 of them were treated with venetoclax. And it occurred that the subsequent venetoclax therapy gave at least twice as long median progression-free survival than those who progressed on pirto. Could you make more comments? That was your poster.
Yeah. So I think, what we did is did an international multi-center study to look at patients who have been treated with non-covalent inhibitors, really with this question that we're facing in the clinic now of what to do next, because there's not a lot of data out there really on therapies after non-covalent BTK inhibitors such as pirtobrutinib. And so for patients who did not have any venetoclax or BCL2 inhibitor exposure before pirtobrutinib, so a lot of these patients had prior chemotherapy, but for example, chemo, covalent, non-covalent inhibitor were some of these patients. Venetoclax worked quite well after a non-covalent inhibitor, and so that does support, there's a median progression-free survival of about 23 months, so that does support you can do within, BTK inhibitors and then go to venetoclax. Of course, we don't have clinical trial data on which sequence is better, but in the absence of that, this retrospective study can support that sequence.
Now, the last case, a 68-year-old man with treatment-naive, symptomatic chronic lymphocytic leukemia, mutated EGHV status, deletions 13q, no 17p deletions, no significant comorbidities. First line, ibrutinib plus venetoclax, and 24 months of ibrutinib, 12 months of venetoclax. 18 months after the end of therapy, progression with B symptoms, lymphadenopathy, performance status 1, again, 17p deletion was not confirmed. So a moderately early relapse after the dual therapy. So is the retreatment of covalent beta-K inhibitors at all feasible? What do you think, Tom?
I think in terms of, it's again an area of kind of evidence-free zone, but we have got some evidence from GLOW study and CAPTIVATE study that actually some of these patients could be salvaged by retreatment with ibrutinib or I+V. So I think in terms of choosing therapy, this is a high-risk patient who's progressed very quickly after finishing fixed-duration therapy. It would be a reasonable option to offer covalent BTK inhibitor to this patient based on the fact that the patient had 18 months progression-free period. But at the same time, I think venetoclax retreatment is an entirely reasonable thing as well. But in these kind of patients, I tend to now offer these patients clinical trials because really that's the best kind of evidence that you can get. So something like a combination trial of looking at the Perto when rituximab versus WenR might be a very good option for this patient, considering how risky this situation is.
So Megan, would you retreat him with venetoclax?
Yeah, I think you can. I think the duration of therapy is really what's unknown here. And then when you're talking about venetoclax retreatment, also thinking, to your point earlier, is this a monotherapy situation? Are you going to do another fixed duration regimen, combining with ibrutinib again, or are you going to combine it with anti-CD20? This is why I think those studies, although small right now, that are looking at patients who get fixed duration therapy and then get treatment with either venetoclax retreatment or a BTK BCL2 doublet are really important. Now, I'll admit I have less experience than both of you, certainly with ibrutinib venetoclax. It's not FDA approved in the United States, for example, but I think this sort of patient is going to become more and more common as we see BTK and BCL2 inhibitors move up front. So the duration of remission is really what's uncertain here. So again, explaining that to the patient and kind of keeping an eye on things and planning for the next stage.
So somehow we think about pirtobrutinib as a drug used in third or third line plus therapy, but here we had both BTK and BCL2 inhibitors in the first line. Would you therefore consider pirtobrutinib?
Yeah, I mean, I think it's a consideration. I think I would probably try to do the covalent inhibitor retreatment based before that, just given the treatment options. But I'll acknowledge there's not a lot of data there, and I do think pirtobrutinib would work. I think the question is, what would you expect that duration of remission to be in a patient like this, which is really unknown.
So 68 years, that's the youngest patient we are presenting. What about CAR-T?
I think that's the big question really here, that if this patient is fit enough, whether you will offer this patient cellular therapy. And I think the main question then comes down to me, if you're going to give them, consider for an allogeneic stem cell transplant, I think you need to get them into a decent remission before you go towards the transplant stage. So if that was my goal for the patient and patient was on board with that strategy, then you probably use venetoclax-based therapy to get them into deep remission and then subject them to the allogeneic transplant. The CAR T-cell data is more, showing us that patients had very high-risk disease and they had a lot of disease on board. So we're using CAR T-cell not as a consolidation strategy, but a therapeutic strategy in that phase. And I think in terms of using CAR T-cells when patients are in remission is unclear at this moment in time.
So just a very short summary. In case one, we had a 70-year-old patient with mutated EGHV status, short remission after Venobi, followed by second-line covalent BTK inhibitors, then progressed. So formally, he was a double refractory. So the panel confirmed that the length matters. Retreatment is unlikely to be effective with current evidence, plus patient functional status and age. We would rather advise a non-covalent BTK inhibitors as the next step. In the US, CAR T cells may be considered in a more fit patient. In a second case, which was an 8-year-old patient with covalent BTK inhibitor intolerance, worsening after the best tolerated inhibitor we have, so after acalabrutinib, despite intervention. And there are multiple options which could be considered, and transition to alternative BTK inhibitor doesn't seem to be a recommended option. Therefore, the panel decided that it's either pirtobrutinib or a venetoclax. And once again, underlying the pirtobrutinib toxicity is exemplary low. In the case 3, we had an 82-year-old, so the oldest patient with a lot of comorbidities and 17p deletion. So the nightmare, the worst of the worst. Progression after first-line covalent BTK inhibitors. And this confirmed progression, switching to other covalent BTK inhibitors is unlikely to be effective. Pirtobrutinib is our first choice. However, venetoclax-based regimens, particular venetoclax in monotherapy, should be considered. And the choice does depend from the patient's comorbidities and age. In the last case, that was a relatively young patient, fit, progressing after first-line BTK and BCL2 inhibitor, and there we have a limited data of what to do. Pirtobrutinib is an approved option and possibly the best one to choose. Now, the CAR T cells is somehow more is more difficult. Now, it's my pleasure to say that it's time for questions and answers. So I step back, and you have all 3 of us to execute.
Yeah, well, we can start with some questions that were submitted, and also feel free to come up and you can submit your questions on the QR code, which some of you have been doing. We'll start with those, but come up. So let's take an online question. Then I see we have someone at the microphone. So I think this is an excellent question. So I'm going to pose it to my colleagues here. What do you think of venetoclax and obinutuzumab in the second-line setting? So I guess there's a question of whether you have it available to you, and then there's a question of what you think, despite if you had access.
Yeah, and that's why the poster you mentioned with the revenge is important, because, and also the acala when treatment after the first fixed duration therapy. Those are small studies. Luckily, there are not many patients in that boat at the moment, but it appears that the responses are there. If I have option of choosing between WenR and WenG, the better option would be WenG, but realistically, we don't have a license for use of obinutuzumab in that setting at the moment.
There is a question about the role of challenging with zanubrutinib and venetoclax. Well, I mean, that's... we take possibly the strongest covalent BTK inhibitor, hoping to get a better result than the combinations we are accustomed to. It's not yet approved. I just want to underline with this question that only a couple of weeks ago we got in the first line the Amplify approved. So we may have the acalabrutinib with venetoclax combination or acalabrutinib venetoclax obinutuzumab combination. And I think that I would rather go for approved options.
There's a question.
Hi, I'm Alex from Milan. It's more of a remark than a question, but I would like to know what you think about it. In my clinic, it's happening more and more often to have patients progressing under ibrutinib. And what I found is it's quite difficult to transition them to Venar, which is the only option here in Italy. So Obinuven is out of the desk. Particularly in patients like Bertrand, so the 82 years old who is progressing with these symptoms and splenomegaly, if you interrupt ibrutinib and then start the ramp-up, during the ramp-up phase you are going to experience a rebound of the disease. So you are wishing to have what you are not allowed to do, so a bridge with ibrutinib while you are ramping venetoclax up. So I was wondering if you have been dealing with this kind of situations and which kind of solutions you found in your real life experience.
In terms of moving on to venetoclax, I normally don't stop the ibrutinib till I've got them onto effective dose of venetoclax, and I completely get your point, because this is what exactly happened. You stop a BTK inhibitor and it feels like Richter's at that point. So I normally tend to continue the BTK inhibitor. The first few doses of venetoclax, 2 or 3 weeks, are traumatic for the patient and the clinician as well. But at the same time, if you continue the drug, what I found is that either you give them steroids or continue the ibrutinib till you've got onto the effective dose of venetoclax, and you can then stop that therapy, the ibrutinib at that point. But if you move over to Perto straight away, usually you don't see that much of a problem. This is the problem with escalation of venetoclax dose, which is takes some time before you get to the effective dose.
There's a question here about double refractory patients and the question of potential role of allogeneic stem cell transplant, and if so, what is the bridging? It's a very good question, because I'm somehow not convinced that the CAR T-cell therapies are doing marvelous things in relapsing refractory setting. Now, if we have a young CLL patient in a dreadful situation, perhaps offering him an allogeneic transplant is reasonable. And for a double refractory patient, pirtobrutinib seems to be the ideal bridging. We've done a study in Polish Lymphoma Study Group where we use acalabrutinib as a bridging to transplant, and then we used acalabrutinib after the allo transplant for the first 6 months to cover the period until the immune system recovered. It's not to be used in this case because it's a double refractory patients, but it just demonstrates that using BTK inhibitor is feasible both before and perhaps for the bridging afterwards. So my answer would be to give the patient pirtobrutinib and then perhaps go to the transplant. Now, the difficult decision is that it could have occurred that the patient could have deeply responded to pirtobrutinib, and then the decision when to go for the transplant in a patient in a deep response would depend from the patient's preferences.
I think the only other thing I would say is that once you get debulk the patient and then to do the transplant, and you get a decent remission and you confirm that the transplant is effective for the patient, you can stop Perto and then reuse it again should there is a relapse at any point in the journey of patient's treatment. But that should be kept in mind, but you will have very few patients in that boat.
If I see no further questions, thank you very much for coming to our symposium, and have a good day.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and by the European Board for Accreditation in Hematology. This activity is developed with our educational partner, CLL Society. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/ABM860.